Hey everyone, welcome back, future coding experts, to part 52 of our 100-part CPC exam series. Today's explainer is absolutely crucial because we are diving headfirst into the uniquely math-based world of anesthesia coding. But hey, before we break down those formulas, make sure to like, share, and subscribe to Decode Healthcare with Harshal. All right, let's get right into it.
So, what are we getting into today? Grab your notebooks because we're going to conquer 1. Basics of anesthesia codes. 2. The master reimbursement formula. 3. Tracking anesthesia time rules. 4. Physical status patient modifiers. 5. Provider roles and modifiers. And finally, 6. Qualifying circumstances add-on codes.
Starting things off with Section 1, Basics of Anesthesia Codes, understanding exactly how the CPT manual structures these is our very first step.
So the anesthesia section covers codes 00100 through 01999. Now you might be wondering how they're organized. Well, here is a massive trap on the CPC exam. Unlike surgical codes, anesthesia codes are actually organized primarily by anatomical region. Right? So whether it's the head, neck, thorax, spine, or extremities, you look up the code based on the body part being operated on, not the actual surgical procedure. Seriously, never report the surgical CPT code for an anesthesia service. Total game changer to keep in mind. Okay, moving right along to Section 2, the Master Reimbursement Formula. Let's look at the big picture of how this billing actually gets calculated. Here is the master formula. It's like a giant puzzle. To calculate the total payment, you take the base value units, add the time units, add any modifying units, and then multiply that whole shebang by a conversion factor. It's a pretty simple equation, right? But you really have to know exactly where to find each of those specific puzzle pieces. Now, it's absolutely crucial to understand the difference between base units and time units. Think of base value units as a difficulty score. They're assigned by the ASA, the American Society of Anesthesiologists, based strictly on how complex the procedure is. A simple knee scope is obviously going to have a lower base unit than an open heart surgery. Time units, on the flip side, strictly measure the clock, and they're typically calculated in 15-minute increments. Since the clock is so incredibly important, let's hit Section 3, Tracking Anesthesia Time Rules. Accurate time tracking is heavily tested. The exact start time kicks off the second the anesthesia provider starts preparing the patient for induction, and the exact end time? That's when the provider transfers patient care to the post-anesthesia care unit, or PACU. But what if care is interrupted and resumed? Well, that's called discontinuous time, and you just cumulatively add those blocks together for your final time unit calculation. Just make sure you don't double count any overlaps.
Next up is Section 4, Physical Status Patient Modifiers. Basically, who is the patient and how does their health affect our formula?
You absolutely need to memorize these for the exam. These are your physical status modifiers. So P1 is a normal healthy patient, and P2 is a patient with mild systemic disease. Neither of these add any extra units. But check this out. Pay close attention to P3 through P5. A P3 patient with severe systemic disease adds 1 extra unit. P4, which is a constant threat to life, adds 2. P5, a moribund patient not expected to survive without the operation, that adds 3 extra units. And then there's P6, a brain-dead organ donor, which actually drops back to 0 extra units. Tricky, right?
All right, now that we know the patient's status, let's jump to Section 5, Provider Roles and Modifiers. This is the who did what part of the equation.
Let's rapid fire through these crucial HCPCS modifiers. AA means the anesthesiologist personally performed the service. QY is an anesthesiologist medically directing exactly 1 CRNA. That's a certified registered nurse anesthetist. QK is for directing 2 to 4 concurrent cases. AD is for medical supervision of more than 4 concurrent cases. Then on the CRNA side, QX means they had medical direction, and QZ means the CRNA performed the service without medical direction. You've got to match the right provider combination to pass this section for sure. And here is a very specific exam trap I really want to warn you guys about. Medical direction, using modifier QK, only applies when the anesthesiologist is directing 2 to 4 concurrent procedures and meets strict criteria. The literal second they start overseeing more than 4 procedures, it shifts to medical supervision. That requires modifier AD, and it results in a lower reimbursement. So keep a close eye on the number of concurrent cases in your exam scenarios. We are almost there. Let's introduce the final variable in Section 6, Qualifying Circumstances Add-on Codes. These are your Qualifying Circumstances Add-on Codes. Plus 99100 is for extreme age, so under 1 year or over 70. Plus 99116 is for total body hypothermia. plus 99135 is for controlled hypertension, and plus 99140 is for emergency conditions. Now, the absolute most important rule here, these are add-on codes. They act as triggers for complexity, but they can never, ever be coded alone. They literally always have to accompany the primary anesthesia code.
Wow, we covered a lot of ground today. Let's wrap it all up with a quick cheat sheet and next steps to lock everything in.
Definitely lock this final formula recap into your memory for your exam prep. Just to review, codes 00100 through 01999 are organized by anatomical region. Your formula is base plus time plus modifying units times the conversion factor. Time is tracked cumulatively from prep to PACU in 15-minute increments. Memorize your P1 through P6 patient status modifiers, your HCPCS provider modifiers, and remember, your 99100 series add-on codes never stand alone.
So, what does this all mean when things get really complicated? Can you apply this master formula to complex, real-world surgical case studies where multiple procedures are happening at once? Well, find out in Part 53, where we're going to conquer anesthesia case studies and moderate or conscious sedation coding guidelines. Keep studying hard, trust the formula, and go crush your CPC exam. I'll catch you in the next one.